Hello, thank you for joining us for the OrthoNeuro webinar, Knee Pain, Know Your Options. Tonight's speaker is Dr. Michael Cannone. Dr. Cannone is a board-certified, fellowship-trained orthopedic surgeon who specializes in sports medicine and adult hip and knee total joint reconstruction. Dr. Cannone will be taking questions following his presentation. Please submit your questions by clicking on the Q&A button at the bottom of your screen and typing in the box that pops up. Dr. Cannone?
Thanks, Heather. Looks like there's still some participants getting on. About half of them, I think, are on already. So we'll go ahead and get started here. I'm going to give a talk about knee pain and your options. And then, like Heather said at the end, we can then go to questions.
Dr. Cannone, you're muted and there's no video.
Is it up, Heather?
Yes, I can see you, but you need to share your screen.
Okay. I tried to. Let me. Okay. Is the screen up now?
Yes, you're good.
Okay, so coping with knee pain, options going forward. As Heather said, I'm Dr. Cannone. I work for OrthoNeuro locally in town, and I am fellowship trained. First of all, you need to understand your knee, understand what healthy anatomy looks like and what diseased anatomy looks like. Mostly what we're talking about is osteoarthritis of the knee. There's other forms of arthritis, but the most common form of arthritis that we see is osteoarthritis. And just because you have osteoarthritis doesn't mean that something needs to be done with your knee right away. There's symptoms associated with it, most commonly pain, and we'll talk a little bit about that in a minute here. So this is your healthy knee anatomy, and this is an unhealthy knee here. You can see that there's basically three main structures that form the knee from a bony perspective: the femur bone, which is up here, the upper part of your knee; the lower part of your knee, which is the tibial bone; and then the small structure that's in the front of the knee. It's referred to as the kneecap, or we call the patella. So there's compartments then on the inside of the knee. We refer to this as the medial compartment. And then on the outside of the knee here, we refer to this as the lateral compartment. And underneath the kneecap, we refer to that as the patellofemoral compartment. And you can get disease in the knee arthritically in all or one of these compartments at a time. Osteoarthritis, as I mentioned, is the most common form of arthritis. Affects tens of millions of people worldwide. It's degenerative. It's a breakdown of the articular cartilage in the joint. So there's different kinds of cartilage in your knee joint. As you can see here, the shiny stuff that is not diseased is good articular cartilage. This in the center is diseased articular cartilage. And then when you get down to exposed bone is when we call it arthritis. So it's a whole progression of this disease pattern over time. It's not just like on Monday you didn't have arthritis and Tuesday you woke up and had it. It usually progresses slowly over time. This is meniscal cartilage, this cartilage in between here, and we know that osteoarthritis can be associated with meniscal injury and previous meniscal surgery. So as this talks about here, osteoarthritis is a breakdown and wearing away of good articular cartilage. It causes the bone to be exposed and rub together, and then results in increased pain. That is the most common reason down the road that patients will end up having total knee replacement surgery or partial knee replacement surgery. So when we talk to patients, we want to know, what is their knee pain associated with? Is it just at certain times? Is it with standing? Is it with walking? Is it with walking short distances before you have to stop and take a break, climbing up and down stairs, getting up from a sitting position to a standing position in a chair, kneeling, squatting, bending, those types of things, twisting, turning. Is there any catching or locking in the knee joint associated with this? Is there any giving way associated with it? And with osteoarthritis, what we ordinarily see is we'll see initially pain and or stiffness associated with the beginning of an activity. For example, getting up from a seated position after you've been sitting for a while, driving somewhere in a car, or first thing in the morning when you get out of bed. And then as you get around and move around a little bit, then it's not quite as bad. But if you overdo it, then later that evening you may notice increased discomfort and pain. You can also have swelling, which can cause stiffness in the knee joint. You may have heard it referred to as water on the knee. We call it an effusion. EFFUSION is how it's spelled. And that can cause significant stiffness and discomfort in a knee joint. And then the other thing that you may notice is a crunching sensation when the knee is being used. That's the compression of uneven joint surfaces or cartilage breaking off in the knee. So there are different treatment options in regard to knee pain. There's medical management with oral medications such as Tylenol and anti-inflammatories. There's injections of different types. There's surgical options, and then there's joint replacement surgery. So as far as medical management is concerned, we ordinarily direct you in that path first with behavior modification, weight loss. Obesity is one of the leading causes of arthritic joints in the United States and worldwide, but United States, it's at epidemic levels. And then exercise to help improve mobility in the joint and flexibility. I just read a recent article, and it's kind of counterintuitive because, you know, the more active that you can be, the more controlled your arthritic symptoms are. The more sedentary that you are, the more symptomatic then you become. Physical therapy can help with this also, strengthening and stretching the muscles in and around the joints. And then, you know, some people will come in and ask about glucosamine supplements and tablets and drinks and stuff like that. And I tell them simply that we really don't have any great studies out there that show a scientific basis for recommending glucosamine. But if it's something that you want to try, I recommend that you try it for 90 days, see if you notice a difference. And if you feel like you notice a difference, then continue to take it. If not, then don't waste your money on it. Tylenol is the #1 pain reliever in the United States. Anti-inflammatories are also used for pain management, such as ibuprofen. However, there are a tremendous number of emergency room visits each year because of complications with anti-inflammatories, with patients not using them correctly, suffering gastrointestinal bleeds, as well as kidney failure. So although you can get those over the counter, you should not exceed the dosage recommendations on the over the counter medications, and you should consult your physician before starting them to make sure that you don't have renal insufficiency or something of that nature going on that this may make worse. There's bracing that you can do. This is an osteoarthritis unloading brace. So what this brace is trying to do is put force on this knee on the outside of the knee here to open up the inside of the knee so that there's less contact force on the inside of the knee with walking and activity. This sometimes works well in conjunction with injections. However, you can see it's a big bulky brace. And so in order to get relief with something like this, then you have to wear it. I do have patients complain at times that the brace will rub in areas of contact on there and it becomes uncomfortable. And these are pretty expensive also. So it's not something that, that we recommend lightly. You have to really want to try something like this and be willing to wear it to be able to get a result with it. Otherwise, we recommend that you don't waste your money on it. You can use any other assistive devices, also canes or walkers. things of that nature. But I think that if you're getting to the point where you're doing that, you're probably looking to do something a little bit more invasive to help take care of your symptomatic pain. Injections, I started to talk about a little bit. So corticosteroid injections are the mainstay of initial treatment for arthritic pain. It gives you temporary relief. It's not a cure. It's something that I'll use. For example, I'll tell the medical students or residents or PA students that are rotating with us that, I really don't want to put a corticosteroid into a joint that doesn't have any type of articular cartilage wear in it, because there's been some studies that show that it can actually accelerate the wear of arthritis in a joint, wear of articular cartilage, and accelerate arthritis in a joint of a weight-bearing status like a hip or a knee. So in fact, in hips, I won't do corticosteroid injections at all. And in knees, the horse is kind of out of the barn. So we're just trying to get them some short-term relief, hopefully to put off joint replacement for a period of time. That and the fact that insurance companies now, if we want to do this second injection here, a hyaluronic acid or viscosupplementation injection, then those injections, insurance companies ordinarily will not approve unless you've had at least 1 or 2 corticosteroid injections, an anti-inflammatory, physical therapy, conservative treatment. And recently, in the last year, Anthem has completely not allowed hyaluronic acid injections because of one study that they looked at. If we get to this point where you get good relief with a corticosteroid injection, I really like to jump to these injections. I do think that there's certain patients that will get good long-term relief with this. Outpatients that come in 2-3 years later, what we ordinarily see is about 6 months of pain relief if it's going to help. And it can take up to 2 months before you get the maximum effect of these injections. So what we will do is have you come in, and there's different formulations of them. Once again, the insurance companies kind of regulate which one you get based on whoever they've contracted with. There's some that are 1 injection formulations, and there's some that are 3 injection formulations. The original one, Synvisc, came from Rooster Combs, and it's still available. And it was a 3 injection formulation initially, and now it's a 1 injection formulation. And you can get it in the 3 also. They started using this in horse racing to diminish the amount of joint pain that horses were having while racing. And then somebody said, hey, let's see if this helps with arthritis. So they came up with a formulation for humans, and we've been using it for over 25 years now with decent relief in certain patients. And the thing is, it's not really predictable. So you can't say, looking at an x-ray, wow, this patient's definitely going to get great relief with this injection, as opposed to somebody that no, this patient won't. I've had patients that we've done this injection who've got horrible arthritis, and we don't anticipate them getting any relief at all, and they come back and it's like, oh my gosh, this is like a miracle thing for me. So once again, it's not a cure, but it does give you some short-term relief, lets you get your thoughts together and decide, how bad this knee is bothering you and how bad you really want to do something with it. Because if you get to the point where we're talking about joint replacement, you really need to be the one that makes the decision that you're ready to have it done. It can't be because your husband or your wife or your children or your doctor's telling you to get it done. It has to be you, because you're going through the surgery. And I can guarantee you, if you're not mentally prepared to go through the knee replacement surgery, you're going to end up with a bad result, because the knee's going to end up stiff, and you're going to not do the therapy the way that it should be done, and you will be very unhappy with the result. So if you fail that, you could consider outpatient arthroscopy. Now, if we're talking about arthritis in the joint, I usually will limit arthroscopy to patients that have a functional meniscal tear that's causing mechanical symptoms in the joint. So like the middle picture shows here of this torn meniscus, if that meniscus is causing the knee to feel like it's locking on a patient or giving way, then I might consider arthroscopy. But you can see, looking at that picture, on the top of it here and the bottom of it here, this is bone-on-bone arthritis. So the chance of this patient getting relief with an arthroscopic procedure is kind of like flipping a coin. But you can see over here, this meniscus is kind of flipped under the other portion of the meniscus, and so this can come out and catch in the joint. So if that's really what's bothering the patient, you know, they can get some relief for a period of time after an arthroscopic lavage and debridement. These are all done as outpatients. In fact, most joint replacements are done as outpatients now, or outpatient extended recoveries where you may just spend a night in the hospital. Historically, there was this procedure here called a high tibial osteotomy, where you kind of try to realign the joint to open the joint space up on the arthritic side by changing the angle of this. I think most physicians today, at least that I'm in practice with and practice with us at New Albany, would consider doing a partial knee replacement on a patient like this, as opposed to this type of procedure. Total knee replacement and other surgery after this procedure is much more challenging, as opposed to converting a partial knee to a total knee replacement. So then when we get to talk about joint replacement, who's a candidate for joint replacement? What type of joint replacement are we talking about doing? I don't do this bicompartmental knee arthroplasty. It was kind of a rage that hit the market when it first came out, but the patients did not do real well with it. So basically, our practice is limited to total knee arthroplasty or unicompartmental knee arthroplasty. And with unicompartmental knee arthroplasty, you can get away with replacing the medial compartment, the lateral compartment, or the patellofemoral compartment. So depending on where the patient is symptomatic and how bad the arthritic changes in the rest of the knee will determine whether or not they're a candidate for, and whether or not their ligaments are intact, whether or not they're a candidate for this partial knee replacement. And anytime you go for a partial knee replacement surgically, then there's always the chance that at the time of surgery, when you actually are looking right at the joint surfaces, that the arthritis is so bad in the other compartments that it would require total knee replacement as opposed to partial knee replacement. There are complications associated with surgery, that whether it's this surgery or arthroscopic surgery, there's always the concern of infection, getting a blood clot, nerve or blood vessel injury. So those aren't something we see very frequently. They're very infrequent complications, but they can be disasters in any rate, in the form of any one of them. And then after surgery, depending on if you're having joint replacement or arthroscopy, recovery is usually from a scope somewhere around 2 to 6 weeks. If we're talking about a partial or total knee replacement, partials may get better a little bit quicker, but the data doesn't support that worldwide. Anecdotally, we think they may get better a little bit quicker. And we're looking at, by about 6 weeks, you should be getting around fairly well, and by 3 months, most patients, especially after partial knee replacement, should be able to get back to some form of athletic activity for a period of time. When we talk about joint replacement, I mentioned it previously, we're talking about replacing the arthritic parts of the knee, the diseased knee, with a artificial joint, meaning metal or plastic. In the United States, there's over 600,000 knee replacements done each year. Traditional total knee replacement is what I've done for years, is considered the gold standard. And the majority of knee replacements performed today are traditional knee replacements. There's some physicians looking and working with robotic knee replacements. I'm not certain that that there's any advantage to robotics as of yet today, but there are physicians in our group that are doing them. So if you're interested in that type of procedure, we can get you in touch with them. There's not any long-term clinical data for the robotics or the other types of procedures, but there is long-term data available for traditional knee replacements. And I can tell you that when I started practice over 20 years ago, we were telling patients that we would hope to get maybe 8 to 10 years out of a joint. And here we are over 20 years down the road. And I can say with confidence that the majority of those patients that have had revisions have not really worn me out. It's been because of other issues. Maybe they've had an infection, maybe they've gone on to instability because some of the other ligaments around the knee have become laxed and required a revision procedure to be done. Today, though, we do have some new techniques to our advantage. We have new materials and designs which have made a very good surgery, very successful surgery, an even better option for patients. It's still a major surgery. It's still accompanied with the risks of standard risks of infection, or blood vessel injury, getting a blood clot, but the procedure itself is more technically refined. Before joint replacement is considered by myself or any one of my partners, we want to make sure that we've considered all non-surgical options, including oral medications, activity modifications, attempted weight reduction, and then if in fact physical therapy, if in fact you failed non-surgical treatment, then you have to decide if it's the best thing for you. In our opinion, the best candidate is someone who has daily pain that interferes with their normal activities, significant stiffness in the knee, instability, buckling giving way, or significant deformity causing excessive bow-legged deformity or knock-knee deformity. The more knock-knee deformity that a patient gets, the more we want to get to the operating room quicker with them, because they're the ones that are the biggest risk for a nerve injury. The more that knee gets fixed into that knock-knee position, what we call valgus knee, when we realign that knee to a more straight knee, it can stretch the nerve on the outside of the leg and lead to a foot drop in some patients. So in some instances, we may kind of push the envelope a little bit to help patients make a decision that knee replacement may be the best option for them. This is an example on the left side of the screen here of an arthritic knee. You can see all the brown or red in there, and that's where the bone is exposed. And then demonstrated on the X-ray in the middle of the screen is a arthritic knee joint. So this is the outside of the knee here. This is the lateral joint, where you can see there it looks like that there is some joint surface preserved here. And this is an apparent space, right? So really there's things touching in here. You've got the articular cartilage touching articular cartilage. There's not just really a space in your knee like that. And then when we look at this side of the knee here, the medial side, it's bone on bone. So you can see where the knee's narrowed down to complete loss of joint space there. This patient may be a candidate for a partial knee replacement, but usually what I'll tell patients is, where do you hurt? And if they come in and they grab their knee and they say it hurts all over, then in my opinion, they don't do real well with partials. If they come in and say it hurts right here and they have a correctable deformity and the patellofemoral joint looks pretty clean, then we can consider doing a partial knee replacement for them. This is an example of a total knee replacement. This was done with a custom implant. So this implant is one that we've been putting in recently. It's custom made for your knee. So it's a one-of-a-kind implant. The only one ever made like it is yours. And it comes with custom inserts, and it reproduces your anatomy in your knee so that you don't have to release a lot of the ligaments that you have to in conventional knee arthroplasty. Our hope is that in doing this, it's first of all unique to you, and second of all, it feels more like a real knee to you, not a fake knee. This is an example of a partial knee replacement here. This is, you can see on the picture on the left here, the arthritis is primarily affecting this part of the knee on the medial side. This is an X-ray demonstrating that. And then this is an example of a partial knee that's been put in there. This is a fixed bearing knee. The one that I'm currently putting in is a mobile bearing knee. There's a long history, some 30-year survival rates of the knee joint. So it could be something that is put in for a long-term fix, or something that can be put in for maybe somebody who's younger that is going to need to be converted to a total, but you don't want to put a total in right away, and it can be easily converted down the road to a total. And this is this similar example of a patient that has lateral compartment arthritis that's had a lateral uni put in. Lateral unis are usually fixed bearing, and this actually was the duo, so they replaced this patellofemoral compartment also. But like I talked about earlier, these really didn't do real well long term. Potential complications of joint replacement or any surgery. We talked about infection, blood clots, nerve or blood vessel injury is not up here, but that should be one also. And then there are also the medical complications. So in our practice, we don't do medical clearance ourselves. We may tell you that, sure, your joint looks like it's a candidate for a joint replacement or a surgical procedure, but the medical doctors will decide whether or not you're a candidate to get that done or not. If they clear you and say that, yeah, your heart's good, your lungs are good, you're not at any higher risk to have surgery than anybody else, then it's something that we could consider. But we've had patients come in and say, you know what, you're either going to replace my knee or my hip, or that's it. I'd rather do that than live right now, because that's how bad it's bothering me. I can't function the way that it is. And so we have to weigh the risks with the complications, potential complications. Long term, what we see with implant complications is loosening or subsidence into the bone, polyethylene wear, and persistent pain. Persistent knee pain after joint replacement surgery is an issue. We don't know exactly why. Some patients have it, some patients don't. It's obviously not something that we shoot for. We want patients to be pain-free as much as possible. But there are unsatisfied patients after knee replacement surgery, and that's one of the reasons that we're exploring the personalized implants that are custom to your knee. And then what to expect after surgery. So typically we'll do knee replacement surgery, whether it's partial or total knee replacement, either as an outpatient or an outpatient overnight stay. It can be done at the hospital, it can be done at the surgery center, and then we'll begin your rehabilitation that day of surgery. So you will get up and walk that day, which is part of the rehabilitation process, and you will, in fact, start working very quickly to regain your range of motion, strength, and proprioception in the joint. In addition to that, we will either do home therapy or outpatient therapy after surgery for the first couple of weeks at home therapy, or outpatient after that for 4 weeks. As soon as you're out of surgery, you'll work with therapy, and we talked about walking that day. You'll be full weight bearing on your joint as tolerated. You'll use a walker or a cane. Eventually go from a walker to a cane to nothing at all. And then the long-term result of your knee surgery is going to very much depend on how hard you're able to work in rehabilitation. I can guarantee you, if you work hard in physical therapy and you do what you're supposed to do, get your range of motion back, get your strength back, you're going to go around and tell everybody, I wish that I had this done a long time ago. If not, then you're going to go tell everybody, I wish I'd never had this done. So it's a two-way street in doing that. In addition to that, then by 6 weeks, you should be able to engage in many normal, typical everyday activities. And then as time goes on, it'll become more that you're not thinking about the knee at all. By 3 months, you should be able to return to sports comfortably for most patients. And then the complete recovery is, I tell patients a year to a year and a half, you'll make gains. So we have options available to us. We have the traditional total knee replacement. We have these personalized implants that are custom fit for your knee, one of a kind. There are insurance companies that are denying those, so we have to battle with them to try to get that. They're designed to fit your particular anatomy and individual shape of your bones. There are studies that show 1 in 5 patients can be unsatisfied with the results of their knee replacement. These patient-specific implants are intended to address some of those problems associated with the dissatisfaction. So some of the things that we're looking at as possible causes for that, the residual pain, maybe some improper fitting and rotation of the implants, functional limitations due to the altered kinematics of the knee, because of the shapes of the implants. This shape of this implant is going to be the shape of your knee, so it's what your knee is used to. And then early implant failure, maybe due to poor alignment or positioning, can lead to this plastic liner in the center here wearing out sooner than later. So once again, these are designed for individual anatomy. They're customized fit. They follow the shape and contour of your normal knee and designed for preserving the most amount of bone in the joint that we can. So we're just taking little slivers out as opposed to large pieces of bone, so that if in fact you end up having to have a revision procedure, there's more bone to work with down the road. The biggest thing that I like about this knee is that you don't violate the ligaments in putting it in. All ACLs are violated to put in whatever knee you're putting in, just about. And so that's not what we're talking about. But the ligaments on the side of the knee or the posterior cruciate ligament behind the knee are really, for the most part, left alone in putting this knee implant in. And like I said, the patients want a knee that's going to feel like the regular knee. If we can give them that, they're going to be very happy. And the cost of this knee, in my experience, hasn't been any more than an off-the-shelf knee, really. This is the company that does it. I'm trying not to make this a commercial for that. But the Conformis, if you want to go do some research on it or look it up on the internet. The other knee that I put in is the Biomet Vanguard knee, which I think is a very good knee also. But you can see that, you know, when you're dealing with a custom implant, you're guaranteed you're going to get full coverage of the bone, minimize the amount of subsidence down the road. The concern with this, when you don't have full coverage, is that this component can sink into the bone over time, causing loosening of the ligaments where it feels unstable, or even loosening of the component where it may need to be revised at an early stage. So once again, these match the shape of your knee. It's your native knee prior to it becoming arthritic. And so it's very unique for each patient. So patient-specific implants are something that is growing in the orthopedic marketplace right now. If you look at when this all started back in 2002, there was very few physicians using it, and now it's increasing kind of exponentially as more physicians become better acquainted with it and more comfortable using it. But I'll tell you, in general, what I tell a patient as far as what type of knee that is being put in them, their best result is going to be the knee that the surgeon that's putting in is most comfortable putting in. So going to see somebody who doesn't do this and asking them to put it into your knee is probably not the best thing to do, to insist that they use something that they're not used to using. So there is some data out there that shows anywhere from 20 to 40% of total knees that are performed, patients could have partial knee replacements. So once again, we look at your knee individually as you come in and determine from a perspective of what we feel is best for you. And even in saying that, if you look at me and say, well, that's great, but I just want the entire knee replaced, I don't want to have to come back and have it revised at at an early, or in 10 years possibly, or 12 years possibly, just do the total now. And some patients will consider doing that. In a very young patient though, we would prefer to do the partial first if we could get away with doing it. The disadvantage is that it's been shown to have a higher revision rate, higher revision risk down the road, and it can become unstable. It can lead to, you can get disease progression in the other compartments in the knee also. It's just looking at some of the ways that they get the scanning of your knee to make the implants. So you schedule the CT scan, you get the knee scanned, they recreate your knee, they create the personalized implant for your knee, and then they bring it to surgery in one box, which the scrubs really love because it takes a lot off the back table. And then when you go through the procedure and then get your therapy, as we talked about, getting better, starts that day. And if I'd have given this talk to you 10 years ago, I would have said that 100% of these are done in the hospital, and I would tell you that each year a higher and higher percentage of these are being done at outpatient surgery centers. So it's more cost effective to do it at the outpatient surgery center. The last time I think we looked at it, the cost savings was about $10,000 compared to a hospital setting. That's all I have. I guess I'll take any questions at this point. Let me see if I can get back over to here. Here we are. Okay. There's the, yeah. So I have a question from Erica. Do you recommend or do the treatment of injection of silicone or that an arthritis clinic does? So I don't know about silicone. I can tell you that the gel injections, we do those. We've done some injections also with stem cells. However, we don't recommend those routinely because we don't know what the long-term results of them are going to be. So silicone, I don't know if that's just what they were telling you that it's like, but that's probably a gel injection is what it is. So I would say that if your insurance is Anthem, that would make sense, that they would not want to, that they wouldn't cover it. That's the one insurance company I know that is not doing that. But the viscose supplementation, I would recommend if you can get it covered by your insurance. You have an appointment for injections in both knees. Pain is 7 out of 10. Climate, temperature, a lot to do with it. How long can I keep doing this before it's time for replacement? So it depends on what's being injected into your knee. Usually we don't like to do corticosteroid injections more than 2 to 3 times a year. If we do have to go to that option, then we want to maybe try the viscose supplementation, which is the Synvisc or gel injections. And if they are not working, then that would be the time to consider it. So I would try the physical therapy, the injections, and then exhaust all of your conservative options. And at that point, if you're not getting relief, then I would consider knee replacement surgery. I think you said you were 72 years old, so you're not getting any younger. The knee that is put in you is going to last you more than likely a lifetime. If we're hoping to get 30 years out of what we're putting in today, 20 to 30 years. And so if you're having everyday pain, it's affecting activities of daily living, it would be my recommendation that if you failed non-surgical treatment, you could consider it now. Anonymous, I'm 70 years old. I have 2 small 14-pound dogs. When I've been down to pet them, I bend at the knees to avoid back strain. However, my right knee feels like a wrench or ratchet. So mechanically, you've got something going on in the knee. you know, depending on how arthritic it looks on X-ray, you may be a candidate just for that, like that one slide I showed in the beginning for arthroscopy. If you may be a candidate just for injection, I'd have to examine your knee and see what the X-rays look before I give you a definitive answer. But yes, there's different options that would be available for you besides knee replacement. I've had cartilage removed from my knee when I was 23. I'm now 78. I've been told that I have arthritis in that knee. I have not had cortisone shots or any type of intervention except exercise. Exercise is the best type of intervention, to be honest with you. And all seems tolerable except when I stand for a prolonged period of time. Yes, so your knee's probably arthritic, but you know, it's not all that symptomatic. So I would think injections would be a good option for you. Obviously, staying active is your best option. Kind of like the Rusty, the Tin Man. You know, the more that the Tin Man's moving around, the less that his hinges are sticking together. So kind of think of it like that, and that's probably why you're doing so well, is because you are active. They said your knee's not bad enough to replace. So I would try the injections to see first. You can try corticosteroid injection first and see how that helps. If it helps and your pain comes back, then I would try the gel injections for you. How much does your weight have a factor in recovery, and what does the cost for self-pay? I don't know what the cost is for self-pay. There's different costs involved in knee replacement and surgical procedures. So there's the surgeon's fee, there's the facility fee, there's the anesthesia fee. There's what are billed charges and what are accepted or negotiated reimbursements from insurance companies. So usually with somebody with self-pay, we'll try to negotiate some type of lower fee with, so that they can afford to get the procedure done if it's something that they really want. But it's not inexpensive, to say the least. There are people at the office that can look into that for you. If you're interested, you can contact the office and get some prices from the billing department. Is 78 years old too old? I tell patients all the time that we have chronologic age and we have physiologic age. So in my mind, there is no age that's too old. It's from a chronologic perspective. From a physiologic perspective, we see 50-year-olds that look like 80-year-olds and 80-year-olds that look like 50-year-olds. So age is not a contraindication with this, but your physical makeup may be the contraindication of that. So if you've got that heart disease, smoke, can't walk, because of your heart and lungs, not because of your arthritic joint, so to speak, then you may not be the best candidate for surgery. But at 78, you're absolutely not too old. Baker's cyst is not the problem in most cases. A Baker's cyst is caused because of something going on in the joint, whether it's arthritis or a meniscal tear or something of that nature. That is usually the result of the problem and not the primary problem. Where was I at here? It's harder to get a custom knee implant approved with most help. No, we haven't run into that, Rodney, that it's not. Some insurances they have said when we were looking at doing other knee implants that they don't approve custom implants, but I have not had one custom implant that we've tried to get ordered for a patient denied as of yet. How long does it take to have the custom parts made? Usually takes at least 6 weeks. The other knee replacement that we do is also a very good knee replacement, and we do scans for those also, so they're customized. Not the implant, but the cuts and the anatomy are customized, and so those implants take anywhere from 4 to 6 weeks to get regardless of which one we're using. What injection do you recommend when insurance denies Synvisc? The only injection that we can do if they deny Synvisc would be a corticosteroid injection. If stem cells is something that you're interested in, that's not approved by any insurance anyways. It's an out-of-pocket expense. And I don't know the exact cost of the stem cell injections, but I think you're looking at an out-of-pocket of $1,000 or more, depending on how much we use and how frequently you get that. Now, that's one of the reasons that we don't really push or advertise about stem cells, because we don't know what the long-term results of them are going to be, first of all, and second of all, it's out-of-pocket cash. So if we're going to be taking cash from somebody to help them get better, we better be sure that what we're offering them has a good track record of making them better. What causes the pain to go down to your foot when you have knee pain? Well, that's a good question. It could be, everything's attached, right? Your fibula is attached up there, which is a smaller bone around the knee. It could be the fact that your deformity is so bad that it's throwing off your foot and ankle anatomy also. So if the knee's too bowed out or too knock-kneed in, it can cause issues like that. Especially if it's too knock-kneed in, we have a lot of patients get ankle pain along the inside of their ankle, putting stress on what's called the posterior tibial tendon. And it can be coming from another source. It could be coming from your back. You could have what's called radicular pain going down your leg, and you're feeling it below the knee going into the foot. So you can have more than one thing going on. You can have an arthritic knee. You can have problems that are going down to the foot because of the arthritic knee alignment, because of something going on in the foot or something going on in the spine. There's multiple reasons that could be. Is there an amount of arthritis? Is the amount of arthritis the main determination for total knee replacement? That's a good question. Like I talked about earlier, if a patient comes in and their x-rays look like they may be a candidate for a partial knee replacement, it's something that I may consider. But if they say they take their hand and cover their whole knee up, and even though the other parts of the joint don't look quite as bad, I still would push for total knee replacement in that patient, because in my experience, the partial knee does not give them quite the relief that they or I wanted them to have. What about the gel they're showing now on TV for the knee? It's just another form of the gel. There's different formulations of it. They're just advertising it. I think Synvisc works as good as anything, but like I mentioned before, that the insurance companies are pretty much regulating what we can and can't use for the gel injections, and sometimes cost is an issue too. What can you do with a broken kneecap? Well, is it fractured right now? You can fix it. If it's been fractured in the past and it's already been taken care of, then it would be dealt with knee replacement surgery at that time, or maybe even arthroscopic surgery to put off knee replacement surgery. But at the time of knee replacement, if that's what you're talking about or concerned about having, it would be dealt with at that time, because in total knee replacement, the kneecap in most cases is a resurfaced structure. So you will thin the kneecap with a cut and then cement a plastic button on the undersurface of that kneecap to take away the pain associated with it. If you have knock knees, can the knock knees be removed at the same time? If you have a knock knee, can the knock knee be removed at the same time? It will be. So if you have knock knees and you're having a knee replacement surgery, your knee should be straightened out. And sometimes if the knock knees I usually don't do bilateral knee replacements or both of them at the same time. But with knock knee deformity, that's one of the indications that sometimes I'll do them both at the same time, because if we don't, then the knee that is not being done can affect the outcome of the knee being done. Brian, I'm 35 years old. I recently had a loose body of cartilage removed and a partial meniscus removed this past February. Within the last couple of months, I'm starting to have daily pain. and can't go for family walks without pain. Well, so if you haven't had any physical therapy, Brian, I'd probably do some physical therapy first. I'd make sure that you're not overweight and you're keeping your body weight down. And I would consider doing some injections in your knee. Depending on what the rest of the knee looks like, I'd like to look at the arthroscopic pictures and see what the rest of the knee looks like. You may be somebody that we would consider recommending stem cells to because of your age. And if the rest of the knee looks pretty good, that may benefit you. If it's just an isolated defect in that they had taken out of the cartilage, maybe a cartilage grafting procedure might be the best thing for you. Or if it's completely global worn out, holding on as long as you can, trying to get you to at least 40 years old, and then maybe doing a partial knee replacement. No generic injections, and how are the Carrie, yeah, the generic injections, there's none available, and the pups are quiet. You can't hear them barking in the background. So I wore them out tonight before I gave this talk. We went on a little 6-mile run, but they're doing very good. Thank you for asking. Brad, you have given me a series of 3 injections a year ago. I've gotten a lot of relief. Feels like it's wearing off, and I'd like to have physical therapy sessions. Can you support that decision? Yes. So what I would recommend, Brad, is that you come in and get another series of injections, and then after the completion of the injections, then do the physical therapy. That would probably be the best option for you. Bob, both knees if one is far worse than the other. So if we're talking about replacement, Bob, I would recommend doing the knee that bothers you the most first, and then the other knee after that. Sometimes the other knee will feel better. Sometimes it'll feel worse. It depends on what the x-rays look like. Marcy, I had a meniscus repair done in June on the inner side of my knee. It gave me a lot of relief after I went through physical therapy. However, in the last 3 weeks, it's getting more difficult to walk without pain. The more I walk, more pain I'm in. So I would say, Marcy, that you would be a candidate to come in for some injections and see how your pain is relieved with that. That's what I would recommend next. Wow, that was a lot of questions. 21 questions. Are there any other questions?
Oh, there's another one that just came in.
22 questions. I don't see it. Wait, maybe it's up above that one. Lisa, thanks for doing this webinar. Lots of good information. And I was curious about the dogs too. If you're looking for suggestions for future webinars, how about shoulder pain? Sure. You got that, Heather?
I got it. Yep, it's on our schedule.
Okay. We will do that. Yes, the dogs are doing very good. They're 2 years old now. They're very strong. And we're trying to get them more socialized so that they're more friendly. But they are amazing animals, I'll tell you that. Stoney in particular is an Olympic athlete, I think.
Dr. Cannone, do you have time for one more question?
No, there's about 4 more questions.
Okay.
Thank you. That's a thank you. All right, Connie, can the plastic between the metal be replaced if it wears out after 15 years? I have bilateral hip replacements and was told that the plastic can be replaced instead. Yeah, it all depends on what that looks like, Connie. So in your case right now in our group, if that's what you have going on, I'd recommend you see Dr. Palmer and talk to him about that. As long as the cup implant and the femur implant are stable and not loose, then yes, you can just get away with replacing just the plastic insert in between them. Roger, thank you for your help. Denise, once your patient has had a total knee replacement, are they a candidate for the eye total replacement when revision is needed? No, the eye total knee replacement, Denise, is just for primary knee arthroplasty at this point. I anticipate down the road they may be looking at some revision options, but for right now it's just for primary total knee replacement. But even that being said, it's the next step in knee replacement surgery. The stuff that we were putting in before that, I really think is going to last 20 to 30 years in and of itself. So I don't think that if you've had a regular knee replacement, a conventional knee replacement, that it's going to wear out any quicker. Marcy, the injections did work very well, but each time they lasted less and less. Yes, that's the problem, Marcy. So as time goes on and the arthritis progresses, then that's what we see, that the injections don't quite last as long, and you may be getting closer to wanting to consider doing something more if that's happening.
I think that's all the questions. Thank you, Dr. Cannone.
So wait, there's something else there's a group chat here also. Getting a lot of feedback. Echo, that was from you. So class B placement, where is that after? Yeah, I answered that one. Once patient, yeah, I answered that one. When you say it lasts 20 to 30 years, what happens after 20 years? So Connie, you asked that. That was in a chat question, but if after 20 to 30 years, if it's worn out, then it needs to be revised to a revision total knee replacement. And that's why we try to get you to wait till at least 40 or older to get a primary put in or put a partial in first, because when you get a revision replacement, it's not like going to the car dealership or the mechanic and changing the oil filter on your car. You have to take out the implants that are in there, put new implants that are in there, which take away more bone in the joint. And so if you're going to have a revision, we'd hope that it just be one time. Okay. Are we good?
So we are almost at the end of our hour. We have one more question from Roy. If we can finish that, and then we'll end the session. Roy asks, after I have been sitting for an hour or so, I stand, my knees, especially my left knee, is very weak. I received injections, joined the Zoom meeting about 30 minutes late. Sorry if this is a question that's been asked.
No, Roy, it hasn't been asked, but so, that's typical. It sounds like partly typical what we see with arthritis. So after you've been inactive or sitting for a period of time, or even just being inactive, really, just not moving or doing anything, we'll see increased discomfort. And I talked a little bit about the Tin Man earlier, and once you get up and move around a little bit, you may notice that it's not quite as bad, but if you overdo it, then you'll feel it. If you've had injections in the past and they've helped, I'd recommend that you try them again. If you've had just corticosteroid injections, maybe try the gel injections. And if you have not had any injections of the gel, then I would certainly look into doing that next for you. Obviously, a lot of you I've seen as patients that are on this webinar already. So you've heard me tell you this before in the office. We want to exhaust all conservative treatment before considering intervention and replacement surgery. So that's the way that I operate.
Thank you, Dr. Cannone. This concludes our webinar on knee pain. Our next event will be on Wednesday, December 2nd, titled When Your Knee Pain is Just Too Much. Dr. Mark Gittins will be speaking on current surgical treatment options for the knee pain. Please check out the event on our Facebook page to register. Thank you and good night.
Thank you, guys. Have a good night.